All right, everybody, good morning. It's a pleasure today to be able to share with you some important uh, aspects of ear surgery, and that are the complications. Today we have an invited guest, Dr. Ray Kung, who is a associate or assistant professor at the University of Southern California School of Medicine in Los Angeles. Ray is a um, his residency was at University of Iowa, where he was also on faculty for 1 year before joining the University of Southern California. He did his undergraduate studies at the University of California, Los Angeles, and we have the pleasure of having his lecture today on the complications of ear surgery. So with that said, I'm going to turn the lecture over to Ray, and we're looking forward to an interesting discussion here. Thank you very much, Ray.
All right, thanks, Richard, for inviting me. It's an honor to be speaking to all of you from across the world. So I'm going to be talking about complications of mastectomies, chronic ear surgeries. I don't have any financial disclosures. We're going to be focusing on labyrinthine fistula, sensorineural hearing loss, injuries of facial nerves to the dura, and for bleeding. So labyrinthine fistula, we can think of them as existing preoperative labyrinthine fistulas and then also iatrogenic ones. So for the preoperative ones where you know about it from, say, the CT scans, there's an incidence of about 10% of the population of patients with chronic otitis media with or without cholesteatoma that have a known, usually horizontal or lateral canal fistula. They're usually greater than 2 millimeters in size. They may have a history of vertigo. They have a usually have a longer duration of a history of chronic otitis media. On exam, they may have a Henneberg sign, but you can have actually pretty high false negative rate. They may also have Tullio's phenomenon, where you have loud sounds that triggers vertigo. If you identify a fistula, then well, it's important to identify a fistula preoperatively so you can explain to the patient that they have a significant risk of profound sensorineural hearing loss, up to 20%, and they may need an open cavity mastectomy or a canal wall down. So you have a spectrum of how you can manage these fistulas. One is to do an open mastectomy, canal wall down, leaving the matrix intact so that you don't risk sensorineural hearing loss. You're essentially exteriorizing the cholesteatoma disease. Or you can do a closed cavity, a canal up, and then come back once the inflammation is down from the cholesteatoma or the chronic otitis media, and then on a second stage, remove the matrix. Or you can do all at the same time with the canal up and remove the matrix in a single stage. So in general, you want to leave the matrix down if it is involving the cochlea itself. That's an absolute contraindication for matrix removal. Also, if it's involving the vestibule or multiple sites, or it's very extensive, in general, try and leave it down and exteriorize. Or if the ear is very inflamed and you feel like you're going to tear the endosteum. In this case, they remove the matrix and were able to preserve the membranous labyrinth, the endosteum, which you see here. But if it's inflamed, lots of granulation tissue, cholesteatoma, then you have a higher chance of tearing and causing that sensorineural hearing loss. Also, if it's an only hearing ear, consider leaving the matrix. You can remove the matrix if it's a smaller one. Less than 2 millimeters is the general guideline, or if this is already a non-hearing ear. So how do you remove the matrix if you encounter one? Well, first you got to locate it based on palpation, and you leave that matrix over the fistula until the very end. You want to clean up the rest of the cholesteatoma, get everything else ready, irrigate, and then get ready to remove the matrix with keeping it underwater constantly. You don't want to introduce air or suction out the perilymph or the endolymph. You can use a little cellulose sponge or cottonoid to gently peel off that matrix from the endosteum. Um, but again, leave that matrix if you feel like it's really adherent or it's inflamed. And then if you do take off the matrix and cover it with fascia, then you can put on some bone dust and then cover with some more fascia. So here are examples. All these diagrams that are in this that are in this manner are from Stanford, from Rob Jackler. He has a great. This is actually open source ear surgery atlas that I highly encourage you to see, whether you're a beginner or advanced ear surgeon. And so here's a lateral semicircular canal dehiscence. We've cleaned everything else off and are gently peeling the matrix off here. We're using the cottonoid method that was recommended by Ferrier, and then placing some bone pate followed by fascia. And here we're seeing the snake eyes of the lateral canal and placing also bone pate. So iatrogenic labyrinthine fistulas are most commonly at the oval window from dissecting disease off the stapes, less commonly in the lateral semicircular canal. In general, you want to leave the disease on the stapes if it's very inflamed. You can't find good tissue planes, and you can come back at a second stage. You can also use a laser to reduce forces, direct physical forces on the stapes. If you do try to push the disease off, then your forces want to be directed anteriorly, because those anterior forces are then counteracted by the stapedius tendon. You don't want to be going inferior, superior, or posterior, because that can rock the stapes and dislocate the foot plate from the annular ligament, as you're seeing here. So for lateral canal fistulas, you can prevent getting into the lateral canal by first recognizing what is otic capsule bone. It is this yellowish ivory dense color compared to your surrounding bone. And this picture is actually from Dr. Rotan, a famous neurosurgeon, and he has YouTube videos of 3D images. You can actually wear some stereotactic or the stereoscopic glasses, and he does some very nice dissection of the temporal bone anatomy. You want to, in addition to recognizing the ivory yellow capsule, you want to widely saucerize. We'll talk about that. That just means having a nice broad exposure. And follow the tegmen. So superiorly, always follow the tegmen, identify it positively 100%. That's a tegmen. I've done it myself, and I've seen trainees drill too inferiorly because they think they've hit the tegmen, and they're just drilling and kind of creating a false tegmen. But what you want to do is get right down to it, and obviously try to keep the bone intact, but get down to it where you can see through the bone and see the blue, see that dura, and positively, without doubt, identify the tegmen. If you're pushed inferiorly because you're fooled, you can also get into the second gene of the facial nerve in addition to the horizontal canal. And stay high and forward to find the antrum. We'll talk more about that later. And if you guys have any questions, feel free to interrupt me. So if you recognize that you've caused a fistula and you see snake eyes, for example, then avoid suctioning on the fistula. You can, again, put some muscle, fascia, or bone pate, bone wax. I think this is actually bone wax. You want to put them on antibiotics, especially if it's already an inflamed ear, to prevent labyrinthitis, meningitis, and put them on high-dose steroids. So in the same vein, sensorineural hearing loss can be caused by labyrinthine fistula or by drilling on the ossicles, especially the incus. The vibration is directly transmitted and leads to a high frequency sensorineural hearing loss. So we want to avoid drilling on the ossicles. Here is a flattened portion of the incus, which was accidentally drilled on. If you are planning to remove the incus anyway, then disarticulate the IS joint early, so that it doesn't matter if you hit the incus. And in general, this is more to prevent rocking the stapes. You want to dissect parallel to the malleus handle and parallel to the incus long process. Those are least traumatic and least risk of causing the stapes to, uh, to dislocate. Also dissect anterior posteriorly on the body of the incus. So this is the horizontal canal, and here's the additus ad antrum. We don't see the incus without any water, but if you put some water there, you can actually see through the refraction of reflected light through the water. You can actually see the incus early and identify the depth of it, get a better sense. So this is how you safely enter the antrum, the attic, and expose the incus. So we want to, it's very common, I've done this and I've seen trainees put their drill under the lip here to try and get rid of that lip. But by putting a drill here, your burr is going to be under that ledge and it's going to be hidden from view. And that's how you can injure the incus. So this line demarcates the plane of the lateral wall of the attic. So you want to keep your drill bit lateral to that plane. You don't want to go beyond that or medial to it, because that's how you can injure the incus. And instead, in a stepwise fashion, take your drill bit and keep working your way slowly medially, and you can snap off that last little bit. Kind of similar to how you would remove bone when you're curating the scutum for stapes. Okay, so now onto facial nerve. Any questions so far? Okay, so now onto facial nerve injury. The facial nerve is dehiscent in approximately 10% of chronic otitis media patients without cholesteatoma, and then even higher with cholesteatoma. Most commonly, it's at the tympanic segment near the oval window, because it's actually a point of fusion between the embryologic ossification centers. So these are some different degrees of facial nerve dehiscence. You can have facial paralysis due to disease itself about 1% of the time. And if you intervene and get rid of the disease and the infection sooner, they have a better chance. Most of them recover to a House-Brackman 1 or 2. So iatrogenic facial nerve injury, one of the most feared complications of mastoid surgery, can occur up to about 4% in initial cases. In revision cases, even higher, up to 10%. So how do we avoid this? Make sure you know the anatomy. You want to know all of your landmarks and relationships. Practice, take a temporal bone course. Make the mistakes on a dissection, on a cadaver instead of a real patient, and get through all the boundaries. Intentionally find all the possible limits of your facial nerve and what's close by. Study the CT scan. And for every temporal bone, I study the CT scan in all 3 planes, because each plane gives you different information, and you might miss something if you're not looking at all 3 planes. Use of the facial nerve monitor is standard. Any patient under general anesthesia, even if I'm doing it just a simple tympanoplasty, I put on the facial nerve monitor in case you run into a surprise and you need to do more. Irrigation, extremely important for cooling, keeping the facial nerve cool while you're drilling, and also for viewing. You can see through bone better when you have when it's underwater. Wide saucerization, so broad exposure. And depending on what you read, the most common area of injury, of iatrogenic facial nerve injury, is the tympanic segment. And this is from not drilling, but just blunt or sharp dissection, trying to remove cholesteatoma that's stuck down to that area of commonly dehiscent facial nerve in the tympanic segment, or just removing chronic inflammation. So if it's very inflamed, then leave that tissue down. If you don't have a good plane, come back at a second stage. And the next most common would be the second genu or the mastoid segments. And that's due to drilling and not properly identifying your landmarks and taking this down safely, which we'll talk about. So the most important advice that I have gotten about the facial nerve is to avoid the nerve, find the nerve. So first steps in general for drilling a safe mastoidectomy and also for facial nerve identification is find the tegmen. And you want to find it broadly. You want to, sometimes I tell my trainees actually to start even higher, because a lot of times they make an artificial ledge and they naturally think that's where the tegmen is. But if you start higher up, it's just cortical bone, and you keep going through the same looking cortical bone, and then you'll see something different. And that's going to be for sure the tegmen. Once you find it way high up here, if you're not sure and you see just a little spot, then follow it. Then go inferior, posterior, wherever, just kind of widen that out, get a nice broad exposure. Once you've positively identified, oh, that's a dura for sure, without a doubt, then follow it inferiorly. And that way, you know for sure. It makes it faster because you're not scared and going slowly. You can kind of blast through what you know is just mastoid air cells. So once you follow the tegmen, you're already going to be drilling high. You want to drill forward. You want to drill towards zygomatic root. And the other thing you'll notice that your drill will sound different. It'll sound higher pitched when you're on thin bone on the dura, because the thin bone has a different resonant frequency. And then I'll also follow the superior wall of the bony ear canal towards zygomatic root. And that's how you'll eventually, you'll get to your antrum. Here we've gone through the Kerner septum, and you use a water reflection to see the incus and its depth, and then expose the body of the incus. Most importantly, the entire length of the short process of the incus, so that you see the incus pointer. I've done myself, I've seen trainees not expose enough of the incus, so they think that the pointer is in one area when it's actually not. So it can be misleading if you're not fully showing yourself the incus and the incus pointer. You want to properly thin the posterior canal wall and have the proper angle. You want the angle of this posterior canal wall to be parallel to your line of sight. And that's very important. You can end up, if you're angling away, you can end up going too anterior. If you're angling towards you, then you could end up being pushed too far back, because it might look thin laterally, but medially your canal could be too thick because you're not parallel to your ear canal. And you could end up being pushed back and thinking, oh, I'm drilling in the facial recess, when you're going to be drilling right on the facial nerve. So this is an example of a well done, safe mastoidectomy. And so they started up high, and here you clearly identify the tegmen and follow it all the way medially. You're going towards zygomatic root, following the superior part of the bony ear canal, and you just keep following those boundaries, that little triangle here, and eventually you'll reach the antrum. And in this case, they have exposed the entire short process of the incus well. Here's a lateral semicircular canal. Then the next steps, they probably then did a wide, broad exposure here. And you can see this vertical height, superior to inferior, is very large, because you want to have a nice tall plane of exposure. You can see a line of the facial nerve much better than if you were to see just a small dot in this area. You can see that they've angled the microscope parallel to the posterior canal wall. In some cases, you can even elevate some of this ear canal skin. You don't want to do too much, because then you could theoretically get some stenosis of the ear canal. But you can elevate it just a little bit to confirm that you're at the right angle, or the correct parallel angle, and thinning the canal properly all the way from lateral to medial. And here you can see the chorda. Here's the facial nerve. And you can see that they have created a nice broad flat plane, both posterior to the facial nerve anterior to the facial nerve and at the level of the facial nerve. And this is just demonstrating a low-lying tegmen and how important it is to drill high and forward and keep following the tegmen anteriorly, and you'll get to the antrum in most cases. So broad, flat leveled exposure, very important. And you want to, this is an example of of having removed one thin flat sheet of bone at a time. So if you imagine all of these sheets of bone, solid bone, you want to remove it in a flat single plane, one at a time, and eventually you'll see the nerve. It'll show itself to you well. You don't want to have ridges. You don't want to have little lumps and bumps here, because then you'll be fooled thinking, oh, is that ridge the nerve or is that not? And then you can have little craters that you dig into, and that you can injure the facial nerve because you're not actually seeing it, because the ridges are covering the nerve and not helping you identify it before getting into it. I like to tell my trainees that you can imagine your diamond burr. So once you get close to your structure, treat your diamond burr as if it were like brushing off fossils. If you notice when they show pictures of fossils, it's always in a broad, flat plane, and they use a brush in broad strokes with a very light touch. You're using the diamond burr with a very light touch, and you're removing one thin, flat sheet of bone at a time when you're close to that structure, and it'll show itself to you. If you identify something, you're not sure what it is, then just keep following it. Go inferior, go superior. You don't want to go too far superior, because you can hit the horizontal canal. And in this case, this is an example of using a small diamond and drilling in a very small, narrow area. And you have risk of injuring the nerve, of the annulus. So in general, a larger diamond is safer when you're trying to get that broad, flat exposure. Then when you're getting closer, then get gradually smaller with your diamond burr. If you're not sure, is this the annulus or is this chorda, then just follow it inferiorly, and you'll see that the annulus wraps around, whereas the chorda will go towards your facial nerve. All right. So make sure you know your landmarks for facial nerve identification. Your horizontal canal, so it's going to be inferior to that. Your cochlear form process is just below the tympanic segment. And for whatever reason, the cochlear form process is very stable, even in the most diseased ears. Something about the tendon and that little piece of bone likes to stay around. And your nerve is going to be just above that. Your oval window, your round window are markers, the digastric ridge, and the incus pointer if you have an incus, and also chorda can help you find the nerve. So this is an example of a patient who had a complete decompression of the facial nerve, and for a motor vehicle accident, facial paralysis, then developed a cholesteatoma and had a canal wall down, and then came to me with a recurrent. And so this is what it looked like intraoperatively. The entire facial nerve was dehiscent. Here you can see the tympanic segment. Here's the cochlear form process with the tentor tympani tendon coming off of it. Here's a lateral semicircular canal. So everything is gone except for your cochlear form process and your horizontal canal. And in this case, luckily, there was a good plane between all the scar tissue and the cholesteatoma. What's not shown here is that I started with the digastric ridge inferiorly and identified the nerve there, and then traced it up. The other things to note is that there are some rare anatomical variants of the facial nerve. For example, this duplication of the facial nerve that might be confused for a chorda tympani nerve. You can have a lateralized mastoid segment. You can have an anteriorly displaced mastoid segment of the nerve. And then one of my professors had told me that the eye cannot see what the mind does not know. So though these are rare, just keep in mind that it is possible. And again, the most important thing is to find the nerve in order to avoid the nerve. Positively 100% identify that's the nerve. And if you're unsure, then just follow that structure that you see. The nerve sometimes often has a little blood vessel on top of it that likes to bleed. And if once you've found the nerve, then you are safe from, well, first of all, it makes your dissection faster because you know you can blast through everything else that's around it. And also if you're doing, for example, a cochleostomy for a cochlear implant, and you don't know exactly where the nerve is and you're trying to widen your facial recess, you can injure the facial nerve on its medial portion if you didn't appropriately identify the nerve and know its depth. All right, so to repair the nerve, if you have a significant injury greater than a third of the diameter or so, then you can repair as seen here, or if there's complete transection, the gold standard would be to do an interposition graft if you can't do a tension-free primary repair, which usually you cannot in the tympanic or the mastoid segment because it's all encased in bone and you can't, it's very difficult to mobilize or transpose a facial nerve, especially because it's tethered at the geniculate. It's very close to the cochlea at the labyrinthine segment, and you can also get vascular compromise the more you try and transpose the nerve like 360 degrees around its circumference. You want to repair the epineurium. Some people say try to do the perineurium, but that's very difficult and it's not existent in certain parts of the facial nerve. Use 9-0 or 10-0 nylon sutures. You can do an oblique freshening of the edges so that you have more surface area for the axonal regeneration. If you're taking a cable graft from a sensory nerve, I've been taught to reverse the direction flip the nerve so that your afferent nerve is going in the same direction as your efferent nerve. Some authors recommend removing the epineurium at least a few millimeters because that grows over the edge of the nerve endings where it's cut and blocks your axonal growth. You may run into a herniated, swollen nerve sheath, and in which case you want to remove the surrounding bone, decompress that, and you can even make an incision parallel to the nerve to give some relief. There are many different repair materials out there. In general, you don't want to get any of the materials in between the nerve endings. But outside of those nerve endings, you can use fibrin, bovine collagen, thrombin, gel foam, skin grafts, nerve conduits. Some of these nerve conduits are made of a collagen, and it creates a barrier from fibrosis and inflammation. You don't want inflammatory cells to get into those healing nerve endings. This is, most people would probably agree that this is not recommended, though the packages will say that you can do this. You would want to get an interposition graft there. For facial nerve transection and repair, you at best can get a Hausch-Brackmann grade 3 with synkinesis, and it takes several months for that to show. If a patient wakes with an unexpected paralysis, if it's immediate, then that may be from local anesthetic, and you just wait a few hours. But if it doesn't improve, then you want to consider exploration, especially if the nerve was not identified intraoperatively. So again, this is highlights the benefit of identifying the facial nerve 100% in the surgery, so you know I did not injure the facial nerve. Then you can avoid having to consider going back in the operating room in this particular situation. You can have a delayed facial paralysis that can be due to herpes reactivation, in which case they have elevated titers. Treat with prednisone acyclovir. Some people even talk about doing herpes prophylaxis with acyclovir if they have a history and you're concerned that they're going to have facial nerve injury from your surgery. mechanical compression. You want to remove any packing that may be pushing on the nerve, and also treat bacterial infection. It's controversial in terms of the timing and technique for facial nerve repair, but where I was trained that if the patient has complete paralysis, then in general, you can do an ENOG, and if it shows greater than 90% loss of function compared to the normal side, and there's an absent EMG, and it's within the 2-week time frame, then consider surgery. Now, the ENOG of note is not accurate if you do it within 3 days because Wallerian degeneration has not completed. So this is just to summarize what to do for iatrogenic facial nerve injury. If it's recognized intraoperatively, repair it right away. If it's just a nerve sheath injury, decompressed like we talked about, you can do a partial repair. If much of the diameter is transected, then you might want to just cut the remaining strands and get a better direct repair. If it's completely transected, then do a cable graft or try primary repair. If postoperatively they have facial nerve injury, then and the facial nerve was not identified and it's still paralyzed after anesthetic has worn off, then you want to consider surgical aspiration. Otherwise, you can do some serial electrophysiologic testing. All right, so on to dural injury. So patients with low-lying tegments, especially elderly, or if you're drilling anteriorly where the tegment is lower, or you're using a cutting burr, you have a higher chance of injuring the dura and causing a CSF leak. The cutting burr itself might not actually contact the dura. It might be that because it's a cutting burr, it can catch. And if it catches a fragment of bone that has sharp edges, it can jam the sharp edges of the bone to cut the dura. CSF leak, as you know, can lead to meningitis, rhinorrhea, otorrhea, and you can also get meningocele if you have dural injury. So here's an example of a low-lying tegment. If you have dura that's still intact with bony defect that you've created, usually you don't have to repair it. But if it's a little bit larger and you're worried about encephalocele, then you probably do want to put some bone dust, bone cement. If it's bleeding, if you have some dural vessels that are bleeding, then use some epinephrine first. Try to avoid cautery if possible. But if the epinephrine pledgets, cottonoids aren't working, then you can bipolar. Don't use monopolar. They'll just make a hole in it. You want to repair the defects immediately, and you can treat these, use the same concepts that you use for sinus surgery as you use for CSF leaks and sinus surgery. You can expose the margins of your normal dura to get a better lip to put in your graft, your underlay graft. And you can try to close linear defects with suture, with Prolene, but to be cognizant that those little holes that you're making with the suture can cause little leaks themselves. Multi-layered closure, with most importantly, the epidural layer is what we recommend. You may want to, you can also pack the mastoid with fat, gel foam, different types of bone cement. Usually you don't need to do a middle fossa craniotomy approach. So here are different repair materials. You can use fascia, you can use muscle that's sutured to the edge of the dura, you can use cartilage, you can use mastoid bone, you can use split calvarial bone graft, you can use fat. There's synthetic materials made different out there, Duragen, gel foam, Surgicel. Cook Medical has something called Biodesign, which can be used for tympanoplasties as well. Use bone cement, fibrin sealant. You can also use local flaps, temporalis muscle or pericranial flap. You can use temporoparietal fascia flap. So in this case, we're worried about an encephalocele because the bony defect is large enough, even though the dura is not violated. We're putting some bone dust and covering it with some fascia, and you may or may not use pericranial flap. Here's an anteriorly based temporalis muscle and pericranial flap that's advanced. the techniques for actually placing the graft, you can put an onlay, just putting it here, for example, but that's not recommended as the only thing. You want to make sure you at least get an underlay between the bone and the torn dura. So it's also the epidural space. We'll see the blast plug technique, sandwich, have multiple layers, and you can also obliterate your mastoid. So here's a bath plug technique with some fat that's threaded on suture. It looks like a bath plug is kind of a dumbbell shape around. You can thread some fascia onto it as the onlay portion. Fat can be harvested from the earlobe, which is that fat is more densely packed than fat from other areas of the body. Here's a sandwich technique. Here's the the epidural layer. And here's an extracranial. So in our case, it would be in the mastoid. You have some extracranial packing or intramastoid packing. In this case, he's added an intradural or subarachnoid space layer in addition to the epidural and the extracranial layers. And in this case, we're using some muscle plug, followed by bone cement, followed by fascia. So the bone cement obviously has to be dry before that you can get that bone cement to work. And if you have a very large defect, then, or you have an encephalous seal, then a middle cranial fossa approach can be done with, here's fascia, bone, fascia. In this case, it's just a bone graft followed by bone dust. And here's an intraoperative view of a truncated necrotic encephalous seal that was removed with an intradural fascia, extradural, and then a bone graft. Patients are going to be put on bed rest with the head of the bed elevated, with or without a lumbar drain. And if they still have CSF leak more than 48 hours or so, then consider going back. Posterior fossa, the dura is thinner and it's more challenging to repair. You have to expose more margins of the dura in order to place your graft. And it's also lower and more inferior, more dependent, higher pressure. Neurosurgery consult is important if you have any temporal lobe injury or suspicion. You can also do, in refractory cases, blind sac closure, also known as ear canal closure with eustachian tube middle ear obliteration. Some people call it subtotal petrosectomy. So you invert and close your canal skin, reinforce it with your pelvic flap, remove the remaining ear canal skin and ossicles and TM. You pack the eustachian tube and the middle ear and the mastoid. So here's an example of transecting the ear canal, freeing the ear canal skin from the surrounding tissue, everting it, and suturing it closed, and then you flip your pelvic flap as a reinforcement layer. Okay, so vascular injury. Sigmoid sinus injury being a more common out of the vascular injuries to occur. You have a higher chance of injuring the sigmoid sinus if it's a sclerotic mastoid, in which case, or a hypopneumatized mastoid where the sigmoid is anterior and the jugular bulb is more superior. In some cases, the sigmoid can be very superficial, especially in children. You might just be one or two swipes with a cutting burr and you're directly on the sigmoid. If you're using a cutting burr or a small diamond burr, you have a higher chance of injuring the sigmoid, just like injuring the dura. There are emissary veins that emanate off the posterior lateral surface of the upper sigmoid, and those can be easily managed with bipolar. Then you divide it, and then you put some bone wax on either end. In the sigmoid, you want to avoid placing bone wax because that can thrombose or embolize. Also, you want to avoid monopolar because that'll just make the sigmoid defect larger. You can use a large sheet of Surgicel or gel foam. It's important that it's larger than the hole itself so that it doesn't travel into the sigmoid and embolize. You can also leave a large tail outside to prevent embolization. Cover with cottonoid for 10 minutes or so. And I'm going to share just a brief video that I found online. This is not my surgery, but Here they're using a cutting burr and unintentionally injured the sigmoid. And you can see we're using some Surgicel and just holding pressure and just waiting. And it clots from the inside. And usually these are low pressure systems and they clot relatively readily. So we'll see after holding it for a few minutes or so, you can use a cottonoid and hold it in place with your suction. Leave the cottonoid there while you're doing some other work, and then come back and remove the cottonoid, and it should be good. All right. So let's go back to the so if you have massive bleeding that is not controlled with what we just saw, then you may need to expose the dura around the sigmoid widely and ligate it, shown like this. This is actually the superior sagittal sinus from a neurosurgery textbook. Let's go to the example. Can you guys see the video okay?
Bring the sinus in the area where you want to make the ligation to avoid the rupture of the wall. This is a septal elevator.
So this is Hugo Fish and his videos. You can find it online if you register.
I'm taking
you can see all these
small
videos
hook
for free.
and raising the dura up, meso. Then I will make a small incision through the dura, and you can see the arachnoid tissue there. See dura and the arachnoid tissue. Now, with this blunt needle, I will go through the dura, see the arachnoid tissue there. We'll even open that a little more, meso. Yeah, no. It's only the blunt needle is a little larger than the one I'm using. Yeah, I'm gone through, and I should come out from the opposite side.
So notice the sigmoid is very widely, the bone is very widely thinned.
See the tip in here. This needle is less bent and thicker than the one I'm using. I'm having bicryl, two bicryl going through that opening. Now I can pull the instrument back, cut here, and this one will not be completely tight. If you do this, if you should have an infection, it's a misery, so that there is some possibility of flow of the venous.
All right, so yeah, so he had wide exposure of the dura, of the rest of the sigmoid, and one of the risks of injuring the sigmoid is if you don't have a nice, thin, even layer of bone across the entire sigmoid. If you leave some parts thicker, then those can snap with sharper edges. When the bone is thicker, it's sharper and it can cut through the sinus wall more easily. And so when doing that, you're creating other holes where you're going to create CSF leaks. So you have to then repair that afterwards. In some cases, you may need to open the neck and always have the neck prepped out of the field in case you need to get a great auricular nerve graft or in case you need to ligate the internal jugular vein for complex cases where you're concerned about a complication. You can also use extraluminal packing, or even intraluminal packing with Surgicel or muscle, with again a large piece to make sure that it's not embolizing. So extraluminal meaning between the bone and the wall of the sinus, kind of like your epidural space, or intraluminal. And intraluminally, you want to densely pack with muscle or Surgicel. And in some cases, if you're concerned that this is the dominant circulation side, then you can use these vascular balloon catheters distally and proximally to stop the bleeding while you primarily repair the laceration with some nylons. And if you have a very large defect and you're seeing the lumen and you're concerned about an air embolus, then alert anesthesia, get the patient in Trendelenburg and left lateral decubitus, like shown here. And also flood the area with saline, put some pressure on it while you're getting control. Other areas of bleeding, you may encounter superior petrosal sinus, same concepts. You can usually stop it with bipolar. Jugular bulb can be dehiscent in 7% of the patients, and also can be high in 6%, so above the annulus. And in this case, so jugular bulb is, it doesn't have adventitia like the internal jugular vein does, and also doesn't have the protective dura like the sigmoid does. So that's why it's extremely fragile. You don't want to mess with it. And it's very important to look at that on your CT scans. In this particular case, the patient had congenital dehiscent high riding jugular bulbs bilaterally. He had a canal wall down for cholesteatoma many years ago, and they came to me with a recurrence. And so when I intraoperatively, as I was peeling the cholesteatoma off, I knew that there was this dehiscent jugular bulb, and just decided to leave the cholesteatoma because it was extremely thin. It wasn't very pulsatile intraoperatively. Only when I zoomed in very closely could I see very faint fluctuations of the jugular bulb, and it almost looked like a hemorrhagic bulla, a blister, like if you traumatize ear canal skin with a little blebbing of blood underneath. And so I decided to exteriorize in that case. You want to avoid overpacking, putting a lot of pressure on cranial nerves 9, 10, 11. If you can't control your jugular bulb injury, then ligate in the neck. You can obliterate superior or proximal and the sigmoid. The petrous portion of the carotid artery shown here in blue, the second, or the genu of that, is just anterior and inferior to the cochlea and the cochleariform process, and is also medial to the eustachian tube. Sometimes you get a very thin bone, less than 0.5 millimeter. 1% of cases, it is dehiscent, as it is shown here. And so just something to be mindful of on your CT scan. It is rare to have a carotid artery injury. Usually you get bleeding from the vasa vasorum of the artery. True rupture is very difficult to control, and you want to do direct pressure and packing, resuscitate them, get IR involved. All right, so just to conclude, it is important as an ear surgeon to understand your anatomy front and back, inside out. Know your patients, get a good history and get a good physical exam and be prepared. You want to first recognize that there is a complication, and a good surgeon would have good composure, knowledge, and judgment. So, and always consult someone who has more experience so that your complication is not exacerbated. All right, any questions?
Ray, let me make a few comments. I think that,
Please.
you know, your comment, you made it 3 times, and I think it's so apropos to avoiding complications, is to avoid nerve injury, find the nerve. And I've been a huge proponent of that in all ear disease, probably much more so in chronic otitis media, more so than cholesteatoma. It is imperative. It's imperative because you will injure the facial nerve if you don't find it. Find the nerve first. Leave the disease wherever it is, but find the nerve, and you will not injure it. The other thing that you mentioned when we talk about iatrogenic fistulas, especially fistulas that have been opened, I've used fascia, fat, bone wax, bone pate. One of the things which I don't like using anymore is wax, because I believe that, you know, the wax, because it's a artificial substance, can dislodge and get trapped in the vestibule. It can cause dizziness. It's not going to absorb like an otolith, which would come off of, you know, like in benign positional vertigo. So I get it. I'm kind of getting away from using wax and much more involved with using both fascia and fat, and then putting a cover with both fascia and bone pate. So um, I think that's something else. The other thing fish's ligation of the sigmoid, that is beyond dangerous as far as I'm concerned, because everybody needs to remember that the sigmoid sinus is in the dura, and the back wall of the sigmoid sinus is the brain. Okay. So, to try to do that little maneuver, which head and neck surgeons use all the time, or vascular surgeons on the sigmoid, I'd never do that. I would prefer rather, plugging it, compressing it superiorly, inferiorly, putting balloons in or whatever else, and trying to control the bleeding. Did you have any further comments on that?
No, I totally agree. I have not seen that, and I hope I never have to do that. But yes, anything else first would be better.
Mhm. All right, listen, we've got a lot of people here. We've got 26 people. Let's get some questions going for Ray on anything with relationship to complications of surgery on the mastoid and temporal bone. Okay, anybody have any questions? Open up your microphone, please ask them. Nega, you have any questions from Ethiopia? Waiting to see if he's responding, or it's 11 o'clock at night in Ethiopia.
Oh,
I have one question.
Thank you. Please ask it, Philippe.
In our setup, most of the mastoid anatomies, they have anterior sigmoid, or it's very sclerotic. And when we see on CT scan, there is cholestoma, but when we try to open up, it's very sclerotic most of the time. So how should we deal with this?
yeah. So, I mean, if you can't work around it, you can try to decompress the sigmoid sinus, in which case you skeletonize it first and leave a nice thin, even layer of bone along the entire length of the sigmoid, and then gently fracture, leaving an island of thin, even bone on the sigmoid, and you can kind of push it down. You can sometimes use bipolar to try and shrink a little bit, um, if needed. And I don't know, Richard, any comments on that?
No, pretty much the same. Pretty much the same. Anybody else? Agata, you have any?
Yes. Yeah,
Okay.
I have a question.
Nega from Addis Ababa. Good morning, or good evening, Nega. What can you?
Yeah.
Question?
Yeah. Thank you, Ray, for the nice presentation. I have one question. If you get a patient with facial paralysis after surgery, we never know whether it is iatrogenic trauma or due to edema. So do you keep them on steroids for some time and see the response?
So I definitely would put them on steroids if you have any sort of facial weakness. But it then depends on, if I guess the consideration to go back and re-explore depends on what you think the cause might be. If it's not local anesthetic and that's worn off, if it is, if you're concerned about mechanical compression because of the packing that you put in, then you might want to go back in and remove that. If it doesn't improve within, it's probably several hours, so you're not causing ischemia to the nerve from a nerve sheath compression injury. Or maybe if you didn't identify the nerve, then you'd want to make sure that it isn't transected somewhere. But then again, that's why it's so extremely important to find the nerve and positively ID it, and know that it wasn't injured. That way you can be much more sure, and document whether it was bony covered or not. If it's still bony covered, then you shouldn't be worried about needing to re-explore. Not sure if that answers your question.
Nega, your question.
Yeah, thank you.
Your question takes a whole lecture. Okay.
Yeah.
how do you deal with, facial nerve paralysis, on a patient who's just been operated on? Obviously, if you identify a injury to the facial nerve, a transection, you'll deal with it intraoperatively, or a injury that encompasses a third to half the nerve, you'll, do as much of a, repair of the nerve as possible, trying to avoid putting a cable grafter in. But yet, like I say, the answer to your question is an enormous discussion. So I think it'd be appropriate again, because everybody sees facial nerve paralysis in their practice, be it from Bell's palsy, be it from metastatic prostate cancer, or breast to the temporal bone, trauma to the temporal bone, surgical injury to the temporal bone. It's all real. It's all happening. So I think what we'll do is we'll have a lecture. We've had a lecture before on this. I think it's time maybe again, because our group has changed significantly since we started this 4 months ago, to refocus on that question. So thank you for bringing it up. Okay. Anybody else? Agata, you said you had a question, I believe. Where'd you go? Oh, Agata, there you are. Agata, what was your question? We can't hear you. Agata is from Poland. There she goes. She's talking to us now. Agata, what was your question? We can't hear you. Maybe she's frozen. Okay, well, let's move on. Anybody else have any questions? I think we're good, Ray.
Right.
We will have this lecture on the global YouTube channel. Misha from London is out of town this week, but he will be, in the next 2 weeks or so, he will be building a YouTube channel. This lecture will be on it, as well as all past lectures. Also, just to remind you, towards the end of the month, we're going to 1 day only, which will be Tuesdays at the regular time. I will give you a heads up on that. And then this week, our lecture on Friday will be with Dr. Monfred from Washington, DC. He will be lecturing for us on Friday at 10 o'clock. So again, Ray, thank you very much for taking the time from Los Angeles to join us. Any questions anybody has, please post them on the WhatsApp, and we can get them to Ray. All right. Be well, everybody.
Thank you so much for having me. It's been a pleasure.